Good morning, everybody. I'll be presenting a study on the clinical profile of compressive lesions of the optic chiasma. So we have no financial disclosures. We all know that cellular or supracellular tumors can cause compression of the optic chiasm, but they could be asymptomatic or present to us with varied visual symptoms, varying from mild or moderate loss of visual acuity and visual field to very severe loss of fields and visual acuity. So we need to have certain parameters or certain indicators to look for early diagnosis and this to analyze the prognosis of such patients to prevent further loss of vision. Our purpose in this study was to analyze the demographic profile, the causes, find out the clinical features, and some prognostic indicators to know what could lead to severe visual impairment. It was a retrospective study of 136 eyes in 68 patients with cellular or supracellular lesions taken in a course of 2 years. We assessed their detailed history, the visual acuity, color, and contrast sensitivity, RAPD assessment, visual fields, the OCT of the retinal nerve fiber layer, as well as the macular ganglion cell complex. Their MRIs were looked into, whether they underwent neurosurgery or not, and whether they scheduled for it or not was looked into, as well as their fundoscopy was done. We found that there was no sex predilection. All of them, whether they were male or female, had equal chances of getting it. And a majority of them belonged to the younger adult group, 31 to 40 years. Most of them had good visual acuity, say 6/9 or better, and very few of them, hardly 10%, had lesser. But color vision was abnormal in about 11% of the patients. RAPD could be seen in about 14% of the patients, and disc pallor, which was noted in 38 to 40% of the patients, only after prolonged compression is what we realized. So most of our patients had pituitary macroadenoma, which is known to be the most common cause of chiasmal compression. Others had craniopharyngioma and Rathke's cleft cyst. We did not have patients of other conditions. And the most common visual field defect in our study was a bitemporal hemianopia. But it should also be noted that we did have other field defects presenting to us, like a homonymous hemianopia, quadrantanopia, an enlarged blind spot, constriction of the generalized visual fields, as well as a central scotoma. We did an optical coherence tomography for all our patients, assessing the retinal nerve fiber layer thickness as well as the macular ganglion cell complex. Because of the retrograde axonal degeneration, there would be thinning of RNFL and GCC. And it shows that the loss of nasal ganglion cell complex reflects on the bitemporal hemianopia that is seen. And in case of patients where visual fields are not predictable or reliable, we can always look at the GCC to make out whether they have compression or not. So in our study, the signs of chiasmal compression were reduced visual acuity, reduced color vision and contrast sensitivity, relative afferent pupillary defect, optic disc pallor. And all of these can occur after prolonged compression or in patients in whom the lesion is pretty large or compressing a lot. But the thinning of the retinal fiber layer and the loss of macular GCC could be seen at earlier stages as well in patients where none of the above parameters were seen. So our study demonstrates that pituitary tumors are the most common cause, of which pituitary macroadenoma is the most common cause, while visual fields can be caused by multiple pathologies like direct compression or as a ripple effect or because of previous impingement or vascular shunting. What was known till now was cellular or supracellular tumors can cause chiasmal compression and that bitemporal hemianopia is the most common field effect. But we should also look out for atypical field effects which should not be overlooked in an enlarged blind spot or homonymous hemianopia can also be because of this when the tumor is larger or is extending either anteriorly or posteriorly. And like I already mentioned, the loss of nasal macular GCC on the OCT shows the bitemporal field effect because the nasal fibers from the macula go to the optic nerve on the nasal side and then decussate to the temporal side of the contralateral tract. So with this, we can assess the immediate need for treatment, talk to the neurosurgeons and tell them that there is already compression. So the patient needs to be treated either surgically or medically so that there's no further loss of vision. So early detection of the compression through visual field testing and OCT can aid in quicker treatment and prevent further loss of vision. Thank you.
Thank you, doctor. Actually, I have one question. Do you have any associated, all these cases were proven cases of chiasmal tumors?
Yes, ma'am. All of them MRIs were done.
Had you done in cases of pituitary microadenoma, not macroadenoma, so that you can detect the early progression Was
Yes,
it
we
done?
did have a few cases of pituitary microadenoma. We did not include them in this because when we look at the MRIs, the size of the
See,
tumor
when
was
you have
not
a
enough.
classical field defect, the GCC, nasal GCC is going to get affected in compressive lesions.
Yes.
When you don't have any field defect, your RJC is going to give you a clue whether there is a signs of early compression
Yes,
or
exactly.
not.
Yeah.
Did you have any case of acute onset nystagmus in these cases?
No, none of our patients had
None
that.
of our patients. Any diplopia?
No, none of them had any diplopia or strabismus or any other signs there. These were the only signs we found in our study.
You have any?
Right, yeah.
Thank you.